Over the course of this semester, this class has really made me think about the way that I clinically practice any issues or pathologies with the lower body. And I have been going about this all wrong. I've been actually going about my entire clinical practice wrong because in undergrad, a lot of my preceptors had graduated from the program already, and so it was more of like a traditional thing, like, oh well, this person before me taught me how to do this, like tape an ankle this way, so this is how we do it. And evidence based practice was not really a thing. They just did it because that's what they were told. And this program has really taught me to dig deeper and look at the evidence and decide for myself what will work best for the patients that I have and the patient population. So I think that integrative to unite and combine is the definition, and I really think that I have integrated more evidence based practice into my clinical practice as well as patient centered care. And I have combined those two things to make myself a better clinician. I still have a long way to go, but I think that this class has helped me realize how far I still have to go and how much research it actually takes to have a good clinical philosophy, and that I just need to start gathering as much information as I can. And so this class has actually helped me a lot with the lower body, creating a foundation. So I originally thought that the treatment had several different parts. So there was the pre-participation, the evaluation, the treatment, then return to play. I did not think that all of these were like could be forged together. I viewed them as different parts, but now I understand that they actually are should be unified, and they all play a huge part together. I'm learning that I need to take the time to do the research. I used to fall into the lazy, oh, I don't have time to do the research. I don't have time to look up if this test actually does what it needs to do category. But now I realize that in order to be the clinician that I want to be, I need to take the time to do the research to see if certain tests are have the validity that I want them to, or if certain pre-participation exams do what I want them to. So I really that has really been brought to my attention this past semester. So I'm going to go through all the different steps. So for pre-participation, I have learned that I knew that an age and sex came into like looking at risk factors, but it was eye opening to me to look at the equipment, the game strategies that your team uses, the level of competition, and maybe even the position that the athlete plays as well, or the patient plays as well. Even things like how lax the joints are can be factors that you need to look at in pre participation in order to understand what risks the patient has. I also learned to look at the modifiable and non modifiable risk factors and look at the modifiable ones because those are the ones I can change. I think it's important to develop a prehab like regimen with the modifiable risk factors in order to help the patients. And I think that I really want to incorporate that into my clinical practice because I believe that is one thing that we are missing, or a lot of athletic trainers are missing. And I think that if we focus more on that, it'll help our patients be better in their sports or even like in life. Like if we focus on the modifiable risk factors and help them, then they won't ever have that injury, or they shouldn't have that injury. This helps us look at the evaluation. So the evaluation, I learned a lot about my evaluation and how that, like the different things that I have been doing, that because I was taught in undergrad, that I never researched, that I should have been like researching and seeing if specific tests are actually valid for what I'm doing. The first thing is McMurray's. We were taught McMurray's. That was the end all be all for meniscus tears, when actually Thestley's is shown to be better at identifying that. So now I find myself going to do a McMurray's and be like, actually, like I'll still do it just to see, but if I have time, but then I always do Thestley's if I'm determining whether the patient has a meniscal pathology or not. I also thought the bump test was super reliable because that's what I've always been told. But then through literature, I found that a tuning fork is actually way more reliable. So that was just eye-opening to me that the bump test isn't as reliable as I thought, and I've been using that for a long time. Then I also think that things like the Ottawa knee and ankle rules are super important. This made me think about these rules, and their background really made me think about patient-centered care and how I need to be more, think about the patient's future more than just the evaluation at hand. So I need to think about, like, do they really need an x-ray? Like, am I super positive that they have an x-ray? Or they need an x-ray? Or can I take the time to put that as a differential diagnosis, but then take the time to see if the patient will improve during some rehab, so they don't ever have to be exposed to additional radiation that they do not need to be. So I think that made me think about how I approach things and the research that I need to do and continue to do in order to be a better clinician. I also realized that the evaluation and the deficiencies that the patient has during the evaluation is what I need to focus on during the treatment. I need to look at what they were weak at and strengthen that during the treatment. When we learned about the treatment-based classification system for the low back, that really helped me understand what I was missing in my evaluation, and second, that if I look at the research, there are different things that each pathology you can look at each path in the pathology and the weaknesses, and incorporate certain things into the treatment to help that specific thing. So that was really important to me, to just understand that the evaluation is not just to look at the pathology, it's to look at the deficiencies that are causing the pathology and fix them through the treatment. And looking at the literature for return to play, it helped me realize that I need to assess those weaknesses that are during the evaluation and help make sure that those get back to normal before I let them return to play. I also need to look at the things that predispose a specific injury and develop tests on how to assess if the patient has the correct amount of function to prevent these, so then they do not get injured again. So I need to focus on, this goes back to the modifiable risk factors, and use those, identify the modifiable risk factors in the evaluation, and then use the treatment to strengthen those, and then help assess those in the return to play. So then I am able to know that the patient is going to return to play without injuring themselves further or re-injuring, and really making sure that that is all set up. So I think that I also need to look at the mental capacity, the psychological readiness of the patient to return to play, because if they are not psychologically ready to return to play, then they have a higher likelihood of getting re-injured. So I think that evidence-based practice goes hand in hand with patient-centered care. And I was thinking about all the different parts of my interaction with the patient as separate parts, but I now realize that they all come together in order to return that patient back to play or activity however they would like. Thank you.